Good evening and welcome to blackdoctor.org. And I am your host, AskDrRenee. And today, if you haven't been watching for the last 3 weeks, every Thursday, 5 p.m. Central, 6 p.m. Eastern, 3 o'clock Pacific, we have been talking about allergies because it's Allergy Appreciation Month. And in case you didn't know, I wrote a book, Mommy, I Can't Breathe, which is the modern guide to navigate allergies and asthma. And I have allergies and asthma, which is why I was compelled to write the book. But today we actually have my allergist who actually helped me edit the book, because we have half of the book is my stories, and then the other half we have a lot of medical information with allergies and asthma that might be helpful to you, food allergies as well as environmental, and the different types of asthma and stuff. So, of course, the first thing I need to do is I need to ask everyone to please share the broadcast. So if you're watching on YouTube, if you're watching on LinkedIn, if you're watching on Facebook, make sure you share the broadcast, because I know somebody could use this information. Secondly, I will do my best to read the comments. If you have questions, because we do have an allergy and immunology specialist with us this evening. If you have questions, we will try to get to some of them. So if you can, drop them in the comments. Please, everyone, tell us where you're joining us from. That would be awesome. And so that's what we've been doing for the last 4 weeks. This is the last week of October, Allergy Appreciation Month. So we'll see what we have for next week. But last week I did give you guys a little teaser of one project I've been working on, and maybe I'll show it again. And then this week maybe I have another one. Okay, and we'll get started. So my guest is Dr. James Thompson, who practices in the Chicagoland area. And you guys are going to love him because he's so smart and brilliant. And so here we go.
Hey.
Welcome.
Thank you, Dr. Renee. So good to be here. I'm so
Yes.
honored.
Oh, no, I'm so glad that we can make this happen.
Yeah.
So first of all, today's topic really is diagnosing allergies. And, it's so crazy. Last week we had the Silveras. I'm sure you heard their story. Their young son was in preschool in New York and unfortunately was exposed to one of his allergens and died at 3.
Okay.
And so they were saying how Dina, the wife, was saying how when she was younger, she apparently was having allergic reactions, but the doctors just said, oh, she needs to avoid these foods. And no one ever mentioned the word allergies to her mom. So she grew up and never knew she had allergies. And then she also said when her sons came along, and they both have allergies. So she has one son remaining that's still alive. And she said that the pediatrician said, okay, we'll avoid those foods, and never, ever said, go to an allergist. And as you know, because you read my book, I was really specific to tell people you need to get an allergy or a pulmonologist, an allergist or pulmonologist. Those are the two things you need if you have allergies and asthma. Those are two things. You need one of them. I never had a pulmonologist. I had an allergist, but you got to have one of them. So she was in shock that her pediatrician had never, ever mentioned an allergist, but her sons clearly had food allergies. So let's start at the beginning. How do we diagnose allergies?
Yeah, it begins with making the diagnosis, because if you don't have the right diagnosis, then you have a big chance of not treating it properly or adequately. So yeah, it does begin with diagnosis. So it starts with the history. It starts with the experience of having some kind of alternate response to food. And it could be any food, but there are some foods that are considered high risk. The more common food triggers, like peanuts and tree nuts and seafood, your shellfish and your finfish. But for young children, it can often show up because they have more limited menus with egg and milk and soy and wheat. And they can be the drivers not only for food reactions where they can have breathing problems or swelling or skin problems like eczema. They can also have stomach problems, and they may not be at an age where they can complain specifically and say my stomach's hurting or I'm feeling itchy, especially if they're toddlers or they're infants. So you have to look at those nonverbal signs, like the skin getting red or hives, which are welts, or lip swelling, or the lid swelling, and kind of have a notion that it could be food. And then they should see an allergist, but many times patients are first seeing their primary doctors. And I've had many doctors in the area order blood tests. They're the next best thing to skin tests. When I started practice over 30 years ago, there used to be a big gap between the accuracy of the blood tests and the skin tests. But over about a course of 10 or 15 years, after I started practice, that gap really narrowed. And now the blood test, if ordered at the right lab, at a good lab, is very comparable, falling just short of accuracy with the skin test. The skin test is still what we call the gold standard. So that's why if there are severe allergies, if someone's had reactions, particularly to shellfish or nuts, which we know in this country there are people that die from those kind of reactions every year. We go over those results annually at some of our meetings. Then they should really see a specialist. They should see an allergy specialist. May not even get skin testing. There are some children I don't need to skin test because they've had blood tests that convincingly show peanut allergy or tree nut allergy or shellfish allergy, and that's enough. But they can get counseling. We can find out, are there other factors here? Or do you have a source of epinephrine? When do you use this epinephrine? What arrangements do you have for school or daycare or preschool? There's so many things that go into it that allergists have more time and are trained to talk to their patients and parents about, that the busy primary doctor, pediatricians, family doctors don't have. They don't have that kind of time, and many may not take that time. This was really a tragic situation that you just elaborated on, but doesn't have to be. And we don't see that. It used to be when I started practice decades ago. That was more common. People would find their way to the allergist by some other family member or some other way. But now, since there have been direct-to-consumer advertising, and most people know what antihistamines are now, and they see these billboards, people running away from pollen and the flowers, people are emboldened, and many will ask, well, can you refer me to an allergist? Unfortunately, they still have to ask because some primary doctors just aren't as oriented to the role of allergists. I used to say we're the Rodney Dangerfields. Now I'm dating myself because a lot of people listening probably know who the heck is
Don't know
Rodney
who that.
Dangerfield. But
I do.
but he, but he's a guy that used to always be self-deprecating. He'd always kind of talk about himself and get no. He said, "I have no respect. No one gives me any
Yep.
respect." So we allergists used to think that for years. No one gives us any respect because we don't really have a procedure, a unique procedure, right? Everybody, gastroenterologists scope you and pulmonologists do a scope down the lungs. We don't have that kind of thing. It's more intuitive, but it's important. It's important to know more about what the natural course of the problem is and how to go about it. There are even strategies now to deal with peanut allergy to make it less severe, like something called OIT, oral immunotherapy. There's an FDA approved process for that. So these are things we can talk with our patients and parents about. That's why it's important to see a specialist in that case.
And then I also say that my mom was a respiratory therapist. I don't know if I ever told you that. My mom was a respiratory therapist, but you read the book, though. And so because she was a respiratory therapist, she went to these conferences with allergists and stuff because she was learning about all of the equipment and the new medicines. And so she was always right up there with the allergists. She knew what was, going on. And I always say the primary care doctor, they're not going to the conference about allergy and immunology. So they're not learning about the latest treatments and all these things. And so what they have is, the gold standard of this is what we usually give, but you never know. There could be some new drug on the market, but that person probably doesn't know because they didn't have to attend a conference to learn about that new treatment. And so that was my thing, was that my mom always knew what was going on because she ran the respiratory department at the level 1 trauma center here in Detroit. So she knew, she was on top of it. And that's important because over the years, I was on a whole bunch of different drugs, but everything kept getting better and better. And as I've said before, thanks to Dr. Thompson, I no longer take any meds, thank you. But I carry my inhaler with me every day. It is in my pocket as I sit right here. But I rarely have to use it, which is such a blessing. And the fact that I don't have to worry about taking that lovely Advair every day that tastes horrible.
Yeah.
It's just a wonderful thing. So, but yeah, it's so important that you make sure you go to the specialist because they really are the ones that can help you. Now the skin test, I think a lot of people don't even know what's involved in the skin test. So can you tell us what's involved?
Yeah, the skin test, depending on the age and size of the person, the patient, it's done either on the arms or the back. Usually, if you're school age or older, we can have enough space on the arms. But sometimes we're we don't have enough space, and sometimes with younger children, they'll tend to touch over the sites. So putting it on the back is more practical. Uh, but the most common tests are prick tests. They're called prick tests because drops that represent potential things you're allergic to, be it foods or environmental triggers, are placed next to numbers so we can identify these drops. And they're placed up and down either the back or the arms. And we ask that people for 5 days before that not take any antihistamines. So parents, for dealing with children, we ask them not to give them any antihistamines. So, examples of antihistamines are Benadryl. Um, it's okay to say brand names. I don't know.
Yes,
I'm so used to it.
Zyrtec,
Okay. Yeah,
Claritin.
that's what people recognize them. If I say loratadine and
Right. They'll have
levocetirizine,
no
nobody
idea
knows.
what you're
But
talking
yeah,
about.
so Zyzol, that's the one with the owl that they advertise on TV. Zyzol, Claritin, Zyrtec, Allegra. We don't. Those are long-acting antihistamines, so you have to be off those for 5 days before the appointment. Benadryl, you just have to be off a couple days usually, but they must be off of that because that can block testing. So the drops are put up and down the arms or the back, and they have numbers to identify them. And something that looks like a small toothpick with a pointed tip is used to just breach the skin, just touch the skin. It's not a jab, it's not an injection. No needles are involved. It's just a little prick, a little touch of the skin to breach the skin. And through each drop, sometimes it's a couple of little pokes there. And then we wait about 15 to 20 minutes to see if there's going to be a reaction. Now, the reaction should and most always is localized. That's why it's so exceedingly safe to do it. It's not usually a systemic reaction where you'll itch all over or have trouble breathing or things like that. We use the arms or the back because it's a safe focal area we can use as a testing medium. And so by pricking the skin a little bit, we breach the skin so the skin in that area just gets exposed to that potential allergen. And then if it gets red to a certain degree and rises, then that's a positive test. And then we grade the test, usually from 0 to 4. You may see there sometimes allergists use other scales, but typically 0 to 4. So if nothing happens, it's 0. And then if it's a maximum reaction, it's 4. And then we have something to further make it accurate. We use what's called a positive and negative control. So the positive control is histamine itself, which will make the skin form a little mosquito bite, but it tells us that there wasn't any inadvertent, any accidental intake of medication that might have suppressed it. Some people didn't know that their cough syrup had antihistamine. So we may be clued into that if we see that histamine didn't react. So it should react. So it's going to be usually for most people at least one test is going to be positive. If not, it throws everything off. So the histamine control is used, and then a negative control is used. That's the diluent that all the rest of the tests are diluted with. And if you react to the diluent, that tells us if a lot of tests are positive or all are positive, and it reacts to the negative control, the diluent, then that messes up the test too, because that means they didn't really react necessarily to the allergen. They reacted either to the prick of the skin or something about that diluent. And usually it's the prick of the skin. That's called dermatographia, where the skin can welt up and itch and get red just from touching it, from pricking it. And so we run into that about 3% of the time. Some in the literature, you'll see up to 5% of the time dermatographia. But when that happens, that complicates being able to interpret the tests. But once these are all applied and each drop is pricked through on the skin, then we set the clock for 15 to 20 minutes and then come back and read the test. And people that are very allergic will have multiple sites where they're reactive, where it looks like a big mosquito bite usually when it's reactive. Sometimes it can look like a tiny mosquito bite, and we're measuring so we don't overread these things, but we generally can have a good discerning of what's going on. And we use that to reconcile with the history, because before we even do that, there is a detailed history. I mean, allergists probably spend more time talking about your environment, your home, what happens with seasons and pets and rugs and carpets and all kinds of things, work and hobbies. So we can kind of get an idea of what's in your environment. So then when we look at these tests, we can reconcile that with the test because you can get false positives from skin tests. You may be positive of something that really in reality is not bothering you, but your skin test showed it. So we certainly don't want to treat or mislead you by saying you're allergic to things that don't really match up with what you're experiencing. For example, some people in May and June, when you see those cottonwood seedlings floating around in the Midwest, they identify, oh, I'm allergic to those cottonwood seedlings. They're really not. The tree that molts that is called the cottonwood tree, but that's not pollen. Those are little seedlings that come out that can make more trees if they're lucky, but that's not pollen. It's too big to really get up in the nose, but it's a marker for grass pollen, which is invisible and comes out at the time those seedlings are floating around. And so when people identify with having problems in May and June, I'm usually looking for their grass pollen site to show it. And we do about 3 different species of grass. And so then there's trees and there's ragweed, which almost to the date explodes into the air on August 15th and goes all the way through September, often, if it's warm enough, into October. And at that same time, mold counts are rising because of leaves and the harvesting and the temperature and all of the humidity levels. So then we see mold counts usually skyrocket in September and early October. So you kind of have that kind of convergence. But skin tests are kind of the gold standard for really identifying and confirming allergic sensitivity. And we could do it to foods and environmental triggers.
So I was diagnosed at birth basically with my allergies. So I've just been without, and that's fine. Now at age 10, they said, oh, we should repeat it. I was like, and I mean, I was 10, but I remember it like happened yesterday. And I told Dr. Thompson, there's no way that I will be going through that ever again. So he gave me a blood test when I became his patient because I was like, no. But at 10, I literally had my whole back, both of my arms. And I was allergic to so much, my whole body was just itching. And I just remember I was the last patient of the day. And when I tell you I was crying and probably screaming too, but I know I was crying. And my sister's younger than me. So I'm 10 and my sister is like almost 8. She's sitting there and my parents, and I'm so embarrassed because I'm supposed to be the big sister and I am bawling because I am in so much pain. Now, mind you, my mother sets me up and says, it's just going to feel like a little scratch. You'll be fine. When I tell you I was so mad at that woman, if I knew 4-letter words that day, I would have used them. I was like, I can't believe she said scratch. That was the worst experience of my entire life. And so when I tell you, I think it was because of the number of allergies that I have that it was just out of control. I was so in pain. And so I said, no, we don't have to do it again. I just won't eat it. Whatever. I'm good. And so, like I said, I had a blood test with him and that was fine because because I spent so much time in hospitals, I prefer IVs to liquid medicine. Liquid medicine was always nasty. So I have no problems with needles. So you can shoot me and I'm fine. And so I was like, I'll take a blood test, but I cannot do that test again. Yeah. But so like I said, I'm one and done. One in my memory and done. We won't be doing it again. I just will be without. Now I've had a few scares that have obviously confirmed that things haven't really changed. Okay. Yeah. So, I had an incident with eggs in med school and quickly something happened. And I've had some incidences that I was like, well, clearly we still have a problem. So yeah, I'm good. But it's so important, though, that you figure it out. And, when you have a baby and they tell you to feed them one thing at a time, this is why. This is exactly why. And if your family has no history of allergies, it doesn't matter. Right?
That's right. It's very possible. I mean, it can skip generations. So even when both parents may not have allergies, the grandparents or great grandparents may have. And so, yeah, those genes were passed on, but it takes 2 things. It takes a certain type of gene to possess to give you that risk, and then it takes the environment. And then there may be some other things we don't understand, certain viral
Right.
infections or other things that go into the mix that turn out to explain why one person may be allergic and another isn't. We've seen that with identical twins. It's not 100% concordance with identical twins. One may
Oh,
have
wow.
asthma, one may have asthma, and the other may not. One may have food allergies, and the other may not. It's not 100%, even though their genetic structure, their genetic makeup is exactly the same. So it's more to it than just genes. It's
Yeah.
very interesting. But I sure hope nobody's scared off from getting allergy
No,
tested,
you have
because
to.
what you expect, what you experience, isn't the
It's
common.
not normal. Like I
Yeah,
said, I'm
yeah,
allergic to a
yeah,
lot of
yeah.
things. Like you
You're just
said.
a lot. Exactly,
And so
exactly, and
there was a
especially
whole lot that
food.
was tested because I am allergic to
Yeah,
a lot of it's I mean food and
yeah,
environmental. So I had like I
yeah,
said, my arms were the
yeah,
environmental and my
yeah.
back was the food.
And see, I
And
don't do it that way. I don't. If I know people are, we call it atopic when we kind of, by your history, suspect you're very allergic to things. And when people are atopic like that and they have history of food and environmental allergies before I've even tested them, I'm not going to do all that testing at once. You know, I,
I
I'm
mean, I
gonna,
am 45 and
yeah,
my allergist was amazing. May she
yeah,
rest in peace, Marva Morris.
okay,
But this was, 35 years ago.
yeah, yeah, yeah.
So
Well,
things might have been different.
we don't always do things the same, but I can
Right.
understand your experience. Yeah,
Yeah. So, and she was like I said, phenomenal, amazing. Because I promise you, I probably would not be still here if it wasn't two people. It was her and my mom. If it wasn't for the two of them, I would be a dead girl because my asthma attacks were so horrible, and I literally did wheeze for the first 10 years of my life. I just wheezed every day. What happened was when I went to the hospital, they would get it down to my baseline. And my mom's like, "Oh, this is her baseline. We can go home." And they're like, "What?" She goes, "She just wheezes all the time. It's okay." So yeah, I thank them tremendously. I just like I
yeah,
said, I'm okay. I'm allergic to what I'm allergic to, and I just stick with that, and it works for me. But
yeah,
I think it's really important that parents understand that allergies don't run in the family. And honestly, at this house, I am the only person that has allergies like this. My mother is allergic to melons, and that's it. I can eat melons, but she cannot. So that's
yeah.
it. Now my mother, it's in my mother's family though, asthma and allergies. And so there's, she has an uncle, so my great uncle, and so it is in the family, but no one has allergies, food allergies like me.
Yeah.
Everyone else might have, mold and mildew and, maybe
Yeah.
ragweed or something, but it's nothing like this. Now,
You're
I
the
want
lucky
you to
one.
speak to allergy shots because I'm in a lot of allergy groups on Facebook, and a lot of people are very anti giving their kids allergy shots, which is why I talked about in the book, because I'm a huge proponent for them because they saved me. I have never had a sinus infection. I
Yeah.
don't know what hay fever is. Only because I went to med school do I know. I don't have any of these issues. I used to mow the lawn as a chore, even though I'm allergic to grass. I can run up and down the lakefront after they've, done all of the beautification of the lakefront, and I'm not sneezing, I'm fine. So I really want parents to understand how wonderful allergy shots can be.
Yeah. Sure. I'm glad you asked. Um, w- we see a number of patients here that um, benefit from the standpoint that there are three groups, three groups that tend to respond, or actually three groups that should consider allergy shots. One is the person that has tried everything else. They've tried all the medicines. They've tried the nasal spray and the antihistamines and the environmental controls, and they get referred to us, and we're specialists that are trained to do shots. There aren't other specialists trained to do allergy shots, but allergy specialists. So we won't jump right in when a patient comes in and say, okay, let's get you on shots. We get the full picture of what's been going on. And if it's convincing that medicines have failed, that the quality of life is really not good, missing school, missing work, missing sleep, missing out on sports, sneezing your head off when you're the goalie of a soccer team, a lot of goals, a lot of balls get past you, or in the outfield of a baseball game, or inside, or swimming, and you're having problems. So what we can do is offer something else besides piling on more medicines. besides going to that ultimate that many primary doctors get pushed to using steroids, which
Mm-hmm.
eventually that can catch up with you getting shots or taking oral steroids multiple times a year for your allergies. So that's the largest category. People where medications and environmental controls just haven't been enough. And let's face it, you can only do so much if you're allergic to trees, grasses, ragweed. I mean, what are you going to do? Live in a bubble, right? You got to get out. And so there is a lot of people that are so happy that there's an alternative and there's something that can complement medicines. The second group are those um, that have problems. Maybe they respond to the medications, but they have side effects to the medications. There's some people that get irritation and bleeding from nasal sprays, and those are the cornerstone of managing hay fever, whether it be seasonal or year round. Nasal spray is what really is the one thing. If you ask allergists, if you were stranded on an island and you had antihistamines, you had nasal sprays, steroids, they say, give me that nasal spray, that nasal spray steroid, because it tends to be very effective. But if you can't take it because it irritates you and you get nose bleeding no matter what you do, no matter how you aim it, then that's a problem, because just antihistamines aren't often enough for people that have moderate to severe allergies. And then, so that's the second group. The medicines work, but they're just, you don't tolerate the medicine so well. Or antihistamines that are non-drowsy still make you feel foggy. And I've run into that sometimes too. The third group, which is the smallest group, but a real group, are the people where the medicines work, the medicines are well tolerated, but either the parent or the patient just can't wrap their brain around taking these medicines for months on end or year round. They're really against medicines. And they've come to know, either through the allergist orientation or through reading themselves or family, that allergy shots aren't medicines. Those aren't pharmaceuticals. They're more like vaccines. They work at using something you're already hypersensitive to, but being diluted out very weak to a very weak level. But every time you get a shot to build up, which build up is usually weekly for a while, you get a little more exposure to that thing you're triggered to, such that you build up a tolerance. And so now, when you get to a certain strength and dose of that allergy shot, when you breathe that in, you're not having that same kind of reaction because you become tolerant to it. And it's been since 1911, so we're talking about well over 100 years that allergy shots have been given. But the first 30 or 40 years, we didn't have a clue how it worked. We just knew we just knew it worked. Then the science got behind it. Oh, there's some T cells involved here and some mediators that are involved, some cytokines. These are substances released by cells that talk to each other, and it suppresses that sensitivity. So it works 80% of the time, not 100. When I start people on allergy shots, and we give allergy shots down to age 5, about school age, because that's the time they can at least understand what's happening. They may
Mm-hmm.
not like
Mm-hmm.
it, but they have an understanding by age 5. And so, and I've started people as old as in their 70s and 80s. And we use that kind of model I was telling you to kind of decide whether we're going to offer people shots. And they start off at weekly and they build up to a certain dose and strength, and then we can gradually move to monthly. Usually within a couple of years, they're getting monthly injections until they go off. And it's not forever. I tell people at the 5th year, you aren't going to get to 5 years if it didn't work. If you're in that 20% failure after the first year, we're usually saying, okay, they're not working, we're going to stop. And that, in my experience over 30 years now, that's about it. About 2 out of 10 people, it really doesn't work. But the 8 out of 10 it works are very pleased. And if you take those 8 out of 10, about a third of them, it works so well, they don't need any medicines. They're kind of the poster child or adult for allergies because they are so happy. They don't need any nasal sprays. They don't need any antihistamines. But I don't get people's hopes up too high because that's just a third of that 80%. I just tell them that generally, if you're in that 80%, we're going to find that the quality of life is going to be better. You're going to have fewer symptoms. You may still need to take the same degree of medicines, but probably during non-peak times, if that exists, you'll need less medicine. And that works out for the majority of people.
Awesome. Yeah, I'm just so grateful. I think I had them 2 or 3 years, and I had them
Yeah,
at like at 6 or 7 or something. So I was young,
yeah,
and I'm like,
yeah,
thank goodness. I was like, and also, you know what? Dogs and cats, I don't have a reaction to either. And I don't know if it was the allergy shots as well, but I don't have any
yeah,
problems with dogs or cats. I would babysit people that had them, and I had no problem. But that was definitely something I was allergic to. And my mom also has an allergy as well.
Yeah. Well, one thing I'm running into a lot now are people trying to decipher, is it allergies or is it COVID? Because there was a bit of a shift when the Delta came in the late
Right.
spring and took over. Before the Delta, when it was that Alpha variant and the wild type called the Wuhan for COVID, it was okay. It was still pretty generic because, cough, fever, sore throat, those, that's not very specific.
Right.
But, but still, it was cough, shortness of breath, those type of things. And, sometimes the fifth thing was like, loss of sense of taste and smell. But when Delta came, it kind of changed things to more an allergy twist. So the most common symptoms: headache, runny nose, sore throat, cough. I saw one thing: people that are vaccinated, they were saying that the two most common symptoms are runny nose and sneezing. And I'm like, wow, what are you supposed to go get a test every day? So so that's been something, but I've explained to people that, first of all, if you have allergies, that can explain things. But if you have uncertainty, if there's something different about it, if you have fever, if you have body aches or something that goes below the neck, then you really want to get checked out. Or if you've been exposed to someone and all of a sudden you're having more allergy symptoms, then it's best to just get checked out. But they do overlap greatly, and they cause some sense of concern for a lot of our allergy patients because they feel like, how am I going to know the difference? Yeah.
Yeah, I mean, at Delta, Alpha, whatever variant, I was like, I just don't need to get COVID. So I was like,
Yeah.
I said, my
Yeah.
asthma, we're on a good path here. And I said, this will derail us. I know it. And so I said,
Yeah.
I'll just avoid
Yeah.
it like the plague.
Yeah.
Um,
That's good.
yeah. But the, and then the COVID vaccine, that they were saying that there is something that's used in laxatives. So if you have an allergy to laxatives, then that's, you wouldn't be able to take Moderna or Pfizer, but you could take J&J. And I don't know anything
Yeah.
about AstraZeneca, but I do know on the islands that that's what they've been distributing a lot.
Yeah, that's true. Unfortunately, it's not very common. PEG is the ingredient called polyethylene
Yes.
glycol, and it's in Miralax and it's in some other laxatives. And so I've not, I mean, as an allergist, I've not had anyone come and say, "Oh, I'm allergic to Miralax or laxative." So, but I've had people that have come in nervous about it and they're not sure. They have a lot of allergies, and so we have a way to test them to that component, that polyethylene glycol. We do skin testing to it. That's for the messenger RNA platforms, the Moderna and the
Right.
Pfizer. Whereas for the Johnson and Johnson, that's polysorbate 80, which finds its way into a lot of various products too. But but fortunately, these things are very, very uncommon. So a lot of people can still get their COVID vaccination.
Thank goodness.
Yeah.
Um, but yeah, I was in a focus group about EpiPens, and there was someone in there who had a cat, but she was allergic to cats, and she was wheezing while we were sitting there. And she was saying how she, it was a focus group, so they're asking all these questions, and she's saying how she misses all this work, and I was like, why wouldn't you just get rid of the cat? Like, I just now I am not a pet person because of the fact that 2 out of 4 people in the house were allergic to animals, so we didn't have, and so maybe that's me being sensitive. But I read in another group about a mom who was trying to figure out what they were going to do with the dog because they found out the little boy was allergic. I was like, oh
Yeah.
my God, the kid is allergic. Should we call child protective services on you? Like, because I know what it feels like to be in a horrible situation and not being able to breathe. Please. Oh my
Yeah.
goodness. So that blows me away. Do you run into a lot of patients like that?
Every day. Um, Pets are part of the family. They're like siblings to the children, right? It's like getting
Oh
rid of a
God.
sibling, right?
Right.
And the funny thing about it is the children feel the same way, right? The child is runny nose, sneezing, feeling miserable. They don't want that pet gone. Some parents talk themselves into, well, there'll be some serious psychological issue if we kick this pet out. My child will be depressed and won't go to school and won't eat. And
Oh my
so,
God.
you know, so well, it creates an avenue of approach for allergists. I never assume that that parents won't get rid of pets. Maybe 1 out of 100 times they'll they'll actually get rid of a pet, be it a cat or a dog. But most times they won't, and so I kind of take that in consideration, and we try to do other mitigating procedures, including sometimes they go on shots to the pets.
Okay.
There are allergy shots to dogs and cats, and they actually work pretty well.
Right.
But it's not ideal, and they would certainly do even better if the pet was not in the home. So, but
They
we
wanted my mom and dad to get rid of the carpet in my bedroom, but my mother, I told you she was a respiratory therapist, so she was
Mhm.
like, I think we can do some other things. And so she, well, what they did do, because I had a lot of stuffed animals, is they all had to be put in plastic.
Oh, okay. Well, that's fine. That's
So
game.
she said, you can keep them, but they got to be in plastic. I'm like, okay.
Yeah, yeah.
And
Well,
then,
she just kept the carpet. What you do with the carpet? Just kept it
yeah,
real
she
clean
kept the
and
carpet
vacuum.
because she was able to, she found some recipe for this cleaner to do all of the wood in the room. And then they put some sort of filter on the furnace. So that removed a lot of things in
Okay.
the air. And so I wasn't allergic to my room. So I was
Oh,
okay.
yeah,
Yeah.
she did a great job.
Yeah.
Yeah. Yeah, about 20, 30 years ago, there were some things you could even put on the carpet. There's something called a kerosene, and it would kill dust mites. So you'd brush it onto the carpet and leave it on for either overnight or for several hours, and then vacuum it off, and it really would kill those dust mites. It wouldn't kill all of them, but it could make a difference. And if you repeat those treatments, you could possibly keep those levels low. And when you add other things like special encasements for the pillow and mattress and changing filters
Yes,
on the
that's what I was
heating
about to
pools.
say. We had,
Yeah,
over time, those came out, and so she made sure that I had the special
yeah,
case,
yeah,
mattress pad and
right.
pillowcase. Everything was put that on first, and then whatever,
Yeah, yeah,
nice linen or whatever. But first we put that on, and so
yeah. She did a great job. It helped her being a respiratory therapist,
yeah.
because studies even in recent years have shown that if you just do one thing, it tends to not have much value. But when you do multiple things, when it comes to environmental controls, that's where you see the added factor of it. It seems to be more than just one plus one, two. It seems to be a little bit more synergy there when you do multiple things at once for your environmental controls.
Well, my asthma attacks happened at night, and they would be very frequent in 2 months out of the year, and so they wanted their sleep, and so
Yeah, yeah,
they,
yeah. It does help to get sleep. Yeah, for everybody.
right, because I go wake them
Yeah,
up, and the whole house has to go to the ER, and yeah,
yeah,
so for
yeah,
selfish reasons, they were like, we got to figure this out quickly
yeah,
because this is
yeah.
disturbing everyone.
Well, the other thing that falls on the radar, and most people will not even hear from most of their allergists, is the connection with food and respiratory problems. Um, those that eat less dairy and egg tend to have fewer respiratory problems and skin problems. And if you not only eat less dairy and egg, but also eat a lot of green leafy vegetables, especially that broccoli and kale and Brussels sprouts, things like that, it can really have a very big benefit in how you handle your allergies, upper and lower respiratory, your sinuses and your chest. But it takes some work because we're so used to the foods we eat, and the standard diet here, the standard American diet, also called the SAD diet, tends to foster inflammation. But when you wipe out some of these foods I'm talking about, and you replace those calories with wholesome foods, fruits and veggies, as long as you're not allergic to them, then it can really make a difference.
So he said that because I'm allergic to citrus fruits, everyone. But so no oranges over here.
Yeah.
But and it's funny because I call my little people, my best friend's children, who are no longer quite little, but they had to understand because they coming around, they're peeling oranges. I'm like, you guys, no, 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 Auntie Nene, you can't have an open orange around me. They're like, what? And
Yeah.
so we had to explain allergies to them. But
Yeah.
it's interesting you say that because I am allergic to eggs and I did not drink regular, like I didn't drink dairy milk until I went to college. But I was sick for a long time. But then I started drinking skim milk. And you know, my sister said skim milk is blue. She was like, because it's so thin and there's no fat in it, so it's see-through. I was like, I like my skim milk. So full disclosure, I would drink 2 gallons of milk a week. I liked skim milk, and I would have a cold mug that I drank it in. I loved it. I drank water and milk. That's all I ever drank. So
Is that past? That's past tense, right?
2017,
Okay.
I decided to, I was like, I'm going to go on this diet, and it said no dairy. And I'm like, what am I going to do? But I was like, okay. So breakfast is my favorite meal of the day, and I'm one of those people that a bowl of cereal could be heaven to me as well. So I liked cereal. So I was like, oh my God, what am I going to do? But I was like, okay. So I just said, okay, we're going to quit. So I quit cold turkey. And I was fine. So then after I'd lost some weight, I was like, oh, let me treat myself. I'm going to go buy a gallon of milk. Let me tell you, it wasn't a day. And I was, I could hear it. I could feel it. I was like, oh, they never lied.
There you go. Yeah.
I can feel, I was like, all of a sudden I'm coughing up mucus. I've been fine forever. And all of a sudden, here it is again. And so now I'm a firm believer, and I drink oat milk. And if I have ice cream, it's 2-3 times a year, if that. Like, I really don't eat. And I'm okay with all of these non-dairy ice creams too. I've tried coconut ones. I've tried, what are some of the others that are not nuts? Because I can't have nuts. But I've tried some.
They have rice base. They have hemp base. Yeah.
Yeah. So I've tried
Soy.
some ice creams, and I liked them. They were very good. Like Nana Moo, that was delicious. So I really am like, I just need to stay away from dairy because I don't like the way I feel. I don't like to. And I mean, and I remember growing up doing that. Like I said, I didn't drink dairy, so that was just the asthma. But I was all of a sudden, and I mean, when I tell you it happened like that, like I might have had it in the morning, by the evening, I was like, I could feel it. I said, oh no, this isn't good. So he's right. I've never eaten an egg, so I can't say anything about eggs, but I know that milk thing is serious. And the fact that it was skim milk. So I'm drinking the best one if you're going to drink one.
Yeah, the skim milk doesn't have fat in it, but see, it still has the cow protein.
Protein, yeah.
And it's the cow protein that also can get you. For years, we didn't understand why. I mean, all we knew is you could bring people in that have cough, have asthma, various sinus conditions, test them thinking, maybe they're allergic to milk, and they wouldn't be allergic to milk, but the parents and grandparents would be saying, yeah, they make more mucus though when they drink milk. And the medical profession adopted the fact, okay, it's not allergic, but there's something connected with milk and mucus. This is just too often, too common, right? But we've learned in the last 5 years, or maybe 5 to 7, now we understand it more. This foreign protein introduces a new type of protein into our bodies. There's something called NEU5GC, NEU5GC, NEU5GC. There's a different kind of compound. Now this NEU5GC is what's called a glycoprotein, and it's in the milk and dairy. It's in beef too, but milk, you kind of get a steady stream of it when you have milk and dairy. And what happens is this NEU5GC ends up implanting on the surface of our cells, where we have something that's supposed to be a different NEU5, I think AC, and the NEU5AC is normal. But with NEU5GC, from having milk or any other beef products gets in there, it can drive inflammation. And inflammation means mucus production. It might not only can cause respiratory problems, it can be leading to other sites where there's inflammation in your joints and various other places. Right. And some autoimmune diseases are thought to be driven by this. So NEU5GC is something they're finding explains this to a large extent. You don't find NEU5GC in poultry, in eggs, but it's really more so in milk products and beef products. But we do have a better understanding of why that is and why it doesn't show up as an allergy to milk.
So I have to give you this compliment. Althea Curtis said, love Dr. Thompson, always has been well-versed, knowledgeable, forward-thinking, and cutting edge. I
That
totally
is out
agree.
to you. Thanks
And then
out to
I
you.
wanted to, before we go, because we're almost about to wrap up here, I wanted to definitely make sure that you guys saw this. This is my latest project that is almost ready, but it's going to be ready in 2 seconds. But here you go. No, Renee, You Are Allergic by Dr. Renee Matthews. Coming to your favorite online book retailers soon.
Oh, that's cool for the young people. Absolutely.
Yes.
That's
So
great.
that is the story
Yeah.
of Renee, and
Yeah.
it helped. I'm the only person with allergies in the book. I love it. I'm the only one with allergies in the book. But it's me as a child, and it takes place at the elementary school that I went to, Wood Creek Elementary School in Farmington Hills, Michigan, and so it's it'll help children because I have heard horror stories about the new bullying where if the child has food allergies, people are throwing food at them that they're allergic to. That
Oh,
can be
yeah.
deadly to
Yeah.
most and
Yeah.
some, unfortunately, because I have contact allergy as well as ingestion. So, I cannot have somebody throwing nuts at me or throwing throwing eggs and they're cracking at me. So that was just awful to hear that. And so, I'm hoping that the books, and it's first of a series, I'm hoping that they will help to educate kids so that they can understand, your friend is normal. They just have some allergies or they have asthma, and this is just what they have to deal with. And you can help them to deal with it. As I tell everyone, my sister was my taste tester. My sister tasted everything. And if she said, no, Renee, you can't have it, then I didn't eat it.
She
She
was
might
your
not be
hey
able to tell
Mikey.
me what was in it, but she's like, no, this something isn't right. You shouldn't have this, because she could
Yeah.
eat everything. So, I had advocates like her, and I have friends. Growing up, I had friends, my cousins, relatives that understood this is what Renee can't have, and you guys can't serve this, and I can't smell seafood cooking without getting sick as well. So that's another thing. They would, no, we can't do this. Renee's coming over or whatever. So that's why I wrote the book, and I'm very excited to get it out. But you can go to noreneeyouareallergic.com, which of course I didn't put a thing up here, but you can go there and get on the list, and I will email you as soon as it comes out. But we're looking at probably next week. We should be ready to go. So I'm very
That's great.
excited. Yeah,
That's great.
I
Do
found a
you do
black
I have
illustrator.
Oh, wow. Yeah, I like the cover. That's
Thank
wonderful.
you.
Can I have permission? I've got 10 copies of your book, of this book. And I want to know, because there's this thing called HIPAA guidelines, confidentiality. But I want so much when I hand this book out to say that this is
Yes, of
my,
course.
my patient. So I have your official on record
Yes, yes. And you
permission.
have an acknowledgement in the book. So it says it. I'm
Okay.
sure it says it in there,
I,
in
I don't
that
know.
acknowledgement.
I don't know if that's stand up in court, but
Oh,
okay.
yes. Officially, yes, you can tell people that.
Thank you.
Oh, somebody asked, does having lupus bring on allergies?
Not directly. It can certainly complicate your allergy experience because you have the lupus and you have allergies. They're not mutually exclusive, of course. But one thing I found is the when people have autoimmune disease, which is what lupus is, it drains so much energy, and the treatment for the lupus, usually being some intense immunosuppressive
Steroid
medications,
probably. Mm-hmm.
usually makes your allergies second fiddle. Now, there are exceptions, and you have your own experience, but I don't see a lot of patients with autoimmune problems with lupus and other similar conditions for their allergy problems because they're often on so much steroid or other medicines that suppress the immune system that their allergies are like second, they're either
Yeah.
not that bad or they're just second fiddle to what's going on. So,
Thank you so much. Well, this
all
has
right.
been a wonderful conversation. Thank you so much, Dr. Thompson, for taking time out to join us. And you guys, I will see you again next week, same time, same place, and we'll have another fruitful discussion to help you because health is wealth. So if you do not have your health, you don't have to worry about going to work, picking up the kids, or anything like that. So please know that health needs to be your number one priority because you got to be healthy. And it just so happens that asthma does with breathing, and you've got to be able to breathe. So,
That's right. That's
you
right.
know, but
Yeah.
thank you so much, everyone, for joining me. And I hope you've enjoyed the content this month of Allergy Appreciation Month. And you can watch any of the old ones on the blackdoctor.org YouTube channel, on their Facebook. You can watch them on my YouTube channel, Ask Dr. Renee. You can always follow me at Ask Dr. Renee. I'm Ask Dr. Renee on all the social media platforms. As a matter of fact, I posted my first real TikTok today. You can go check it out. But I will talk to you guys next week. Bye.
Bye-bye, doctor.